Good afternoon, everyone. Welcome to the session delivering urological services during the COVID-19. My name is Joe Phlip. I'm a urologist from Bristol, and I'm co-chairing this session with Sean Allen from the University College Hospital, London. We have a panel of 3 esteemed speakers. The first one is Professor Grant Stewart from Addenbrooke's Hospital, Cambridge. He's a professor of surgical oncology at the University of Cambridge, focusing on surgery-related clinical trials and translational research. As a urological surgeon, he has a specific interest in optimizing management of patients with localized cancer. He is the chair of the Scientific and Education Committee of the Urology Foundation, a member of the Clinical Expert Review Panel of Cancer Research UK, and sits on many other boards, including being section editor of the BJUI. He coordinates the Cambridge Renal Cancer Collaboration, collaborating with a group of over 40 clinicians, translational researchers, and basic scientists across the Cambridge Biomedical Campus. Professor Stewart is also program lead of urological malignancies at CR UK Cambridge Centre. He has over 54 million research grant money and 160 peer-reviewed publications. He has been coordinating the delivery of the recovery trial in Cambridge and also has been involved in the dexamethasone paper in New England Journal of Medicine. He also leads COVID Surge, the world's largest study of surgery during the COVID pandemic. Professor Grant Stewart will be talking on the impact of COVID on surgical outcomes in urology, the COVID Surge study data. Next speaker would be Professor Duncan Somerton, who is the immediate past president of BAUS. He leads the East Midlands Penile Cancer SOPRA Network and has chaired the East Midlands Regional Training Committee since 2009. He has been the chairman of the EAU Guidelines Panel in Urological Trauma and has examined for FRC's urology over 12 years. As most of you know, he has just stepped down from being the president of BAUS. He has also just been promoted to honorary professor in 2020 with the University of Leicester. He has been awarded an honorary fellowship of the Sri Lankan Association of Urological Surgeons and been recently elected as president to lead the Federation of Surgical Specialty Association. Professor Somerton will be speaking on prioritizing urological surgery during COVID-19 pandemic. The last but not the least is Professor John Kelly from University College Hospital, London, delivering urological care using a hub model and how they have adapted during the pandemic. Professor Kelly is a consultant urological surgeon with robotic expertise for bladder and prostate cancer. He is the lead for the London Cancer Urology Surgery Center and the Robotic Surgery Program at UCLH. He is the professor of uro-oncology at UCL, and his research group explores new therapies for bladder and prostate cancer. He is the clinical lead for urology at Westmoreland Street Hospital and also the director of the Chitra Setia Minimal Access Center. He's been the chairman of the UK National Cancer Research Institute, the Bladder Cancer Studies Group, and is currently the chairman of the Scientific Committee of the Urology Foundation. He holds the ORCID Chair of Male Genitourinary Oncology. So, concluding the remarks at the end of the session will be my colleague. But for now, I would like to invite Professor Grant Stewart to do his talk. Thank you.
Thank you very much to the organising committee for inviting me to speak. This has given me a great chance to reflect on the work that my team have been doing on COVID-related research over the last 8 to 9 months. And for me, this started 5 days before the national lockdown, when my friend and colleague, Mark Toshner, who's a respiratory physician at Addenbrooke's and a clinical academic there, asked me if I wanted to repurpose myself as a COVID-related researcher. I didn't realize this was going to last any more than 2 months, but he was very keen to get my clinical trials expertise transferred over to COVID-related trials. And it's clear to me that many of us have been repurposing our skills during the last 8 months. And for clinical academics, this has been around repurposing our research skills towards COVID, and in my case, away from cancer. So what have we been doing? Well, we've been extremely busy. That's been the bottom line, with a range of activities, of course, providing clinical service, redesigning student teaching, educating clinical medical students online rather than on the wards, writing papers and grants and keeping our own research going. In fact, here's a chart from the British Journal of Urology International, and you can see those of us that joined Freddie Hamdy's new editorial board back in March were quite surprised by the increase in the numbers of submissions that we were seeing to the journal, around about 150% of what would normally happen, as people were writing up papers that they'd been meaning to do for a while. Fortunately, those levels have reduced. More importantly, we've been undertaking non-surgical related COVID research. My team have been involved in the recovery trial, and I was very proud that they were amongst the first people to recruit patients at Addenbrooke's to recovery. We got that trial up and running in 7 days, and as many of you will know, those R&D processes normally take about 7 months. We were delighted to see the initial results of dexamethasone reducing mortality in people needing respiratory support. And you can see underlined here the members of our urology team who are members of the collaborative authorship group in the New England Journal of Medicine paper. We've been involved in the vaccine trial, in policy assistance around clinical trials. So this is the data that we published in the BMJ Open, which showed that there are far too many clinical trials relative to the numbers of patients who have COVID, and that needs to be streamlined. And that message was actually taken on by SAGE in order to streamline how clinical trials are undertaken during the COVID period. And then surgery-related COVID research, which will be the remainder of the talk, and COVID surge itself. So what is COVID surge? Well, it was clear to me very early on that COVID surge was going to be the horse to back in terms of surgery-related COVID trials. And it's a platform of studies aiming to explore the impact of COVID-19 on surgical patients and services. You can see here the range of funders that have been involved in COVID surge, and I'm delighted as the chair of the Science and Education Committee for TUF that TUF have become one of those funders and who have acted in a very nimble manner in order to fund rapidly this enterprise. This is a global study, and although it's being led by Anil Bangu, who is a clinical academic in colorectal surgery at the University of Birmingham, Anil will be the first to emphasize these metrics, that it's a trainee-led study with over 50,000 patients recorded on the REDCap server during the first wave of COVID, 2,500 centers, 135 countries, and vast numbers of people who are either directly involved or interested in the study. In terms of the urology data, some of which I'll present to you later on, this has been led by the BURST team. And I'd particularly like to mention Qianyu Gao, who's led that BURST team, and also Vincent Chan, who's a medical student in Leeds, who has provided the analysis of the urology data and the statistics that you'll see later on in the talk. So let me go through the COVID surge data and publications to date. The first piece of work that came out very early on in the pandemic was a simulation around the number of cancelled operations. So it was predicted that 28 million elective operations would be cancelled worldwide, just an eye-watering figure, of which over 500,000 would be in the United Kingdom. 2.3 million cancer operations would be cancelled globally, of which 458,000 would be urological cancer surgeries. 2.5 million benign urology operations would be cancelled globally. And it was predicted, even if we could increase the activity by 20%, that it would take 11 months to clear this backlog. And I'm pretty sure if we ran this simulation now, we'd realize that we're nowhere near that increase in activity and that these numbers are going to take a lot longer to clear. Moving on to the first of the major prospective studies, the COVID Surge Cohort Study. So this was a study looking at perioperative SARS-CoV-2 infection, and that meant patients that developed SARS-CoV-2 within 7 days before or 30 days after surgery. So they're all patients who had the infection, diagnosed by a laboratory swab test, radiologically, or by clinical diagnosis. And clinical diagnosis is key because this is a global study, and some of the countries that were involved in COVID surge didn't have the infrastructure to undertake formal testing. The outcomes were primary outcome of 30-day mortality, secondary outcome of 30-day pulmonary complications. You can see that there were huge numbers of patients that were SARS-CoV-2 positive, 1,100 patients from 235 hospitals, 24 countries, 1,200 collaborators. So you're beginning to see the scale of this study in those numbers. And this paper was published in The Lancet in June. Here are the headline figures. Of those 1,100 patients, 24% died. Of the people who died, 51% had, 51% of patients had pulmonary complications, 38% of those patients died. You can see the breakdown in terms of pneumonia, ARDS, which was particularly lethal, and unexpected ventilation in terms of numbers and mortality. Those SARS-CoV-2 patients who didn't develop pulmonary complications, the mortality rate was significantly lower. So just as we know now, the pulmonary complications are the reason that people die primarily from SARS-CoV-2 infection. What about the urology patients in this cohort? Well, there weren't vast numbers, but the numbers showed that 57% of patients developed pulmonary complications, 32% of patients died. So actually higher than the average for the entire COVID surge cohort study. It was possible to stratify risk of death. So if you were male, over 70, having major surgery, having emergency surgery, then the risk of death was significantly higher. So the take-home messages from the cohort study were perioperative SARS-CoV-2 infection increases mortality and pulmonary complications, that urology patients are at an above average risk, and SARS-CoV-2 infection is now the major driver of death after elective surgery. The next piece of work is the COVID surge cancer study. So this is data that we have up until the 19th of April, 2020, and has recently been published in the Journal of Clinical Oncology, includes 9,100 patients from 447 hospitals in 55 countries. In this study, we're looking at elective cancer surgery, so patients planned for surgery, which was either undertaken or deferred or delayed during the height of the pandemic, and they are not suspected or proven to have SARS-CoV-2 infection, and it includes patients from the 10 major surgical oncology disciplines, including urology, for which there were 436 patients. The initial COVID surge cancer study was looking at the risks associated with different surgical pathways. You can see at the top here, the COVID-free surgical pathway where theatres, wards and ICU are all in green areas. There is no risk whatsoever of contamination of those areas by COVID positive patients, as opposed to all of the other pathways where even if a patient could be admitted to one of these areas or treated in the ITU or the theatre, they were not deemed to be COVID-free. Post-operative pulmonary complications once again were analysed. And you can see here the unadjusted outcomes. So in the COVID-free pathway, pulmonary complications, SARS-CoV-2 infection and mortality were all significantly lower than those patients who were thought to be SARS-CoV-2 free, negative, who were treated in an undefined pathway. Adjusting for case mix, which is clearly very important because, as many of you will realize, in the UK, our SARS-CoV-2 free pathways are often in the private sector, or therefore these patients will have a lower level of risk associated with them. So, but when we adjust for case mix, we still see a significant reduction in the odds ratio for being in a COVID-free pathway. What about the urological cancer patients in the COVID surge cohort? So once again, to emphasize, this is 436 patients managed up until the 19th of April. We actually will have access to 2,700 urology patients for the entire study period. That data is being cleaned at the moment, and Burst will analyze that data once we have it. So of those patients, 173 had upper tract cancers, 126 bladder cancers, 137 prostate cancer. And if you follow these flow diagrams down, you can see that the vast majority actually were operated on during the period between March and July over which this study ran. Of those urology patients, 14 developed SARS-CoV-2 infection, and they're all listed here with some details. You can see they're mainly bladder cancer patients, kidney cancer patients, and penile cancer patients. And of those 14 patients, 3 died of SARS-CoV-2. 21% versus only 2 of the other patients who hadn't developed a SARS-CoV-2 infection, which was 0.5%. So clearly a significant difference there. Interestingly, of the 14 patients that developed SARS-CoV-2, 10 required some form of oxygen support, implying that even if a patient doesn't die, they were quite usually symptomatic and usually of respiratory symptoms. What about safety of surgery during the pandemic? Well, if we take complications, significant complications of Clavien-Dindo 3 or above, we see that if you have an infection, you have a 28% chance of having a complication, versus if you do not have the infection, there is a 2.4% risk of complications from our cohort of urology patients. And when we look at nephrectomies, we're seeing that compared to BAUS 2018 data, there is a reduction in the risk of significant complications during the COVID pandemic, and for cystectomy and prostatectomy, a marginally higher rate of complications, but none of these were significantly different, suggesting that surgery during the peak of the pandemic was safe. So take-home messages here are: to protect cancer surgery patients, we need to provide COVID-free surgical pathways, and also that urological surgery appears to have been undertaken safely during the COVID-19 pandemic. So what's next for COVID surge? Well, Anil Bangu, the chief investigator of the study, I think put it really nicely in this tweet. We're going to see more people coming for surgery with current SARS-CoV-2 with no symptoms, old SARS and no symptoms, old SARS and previous symptoms. And what are the effects of ventilation and surgery in general, and the recovery from surgery on these people? We do have some data to suggest that we need to proceed with caution. If you look here, you can see if you have your COVID swab and are positive within 1 to 2 weeks of surgery or 2 to 4 weeks of surgery, the risk of pulmonary complications or mortality is significantly higher than if we wait for over 4 weeks, when the risks are 0 in the small numbers of patients that we have in the COVID surge cancer cohort. I say small, relatively small, and therefore we need to develop that evidence to show what moving forward with treatments by surgery of patients that have been affected by COVID, and clearly there are going to be many of these, and that data is now being accrued in the Surge Week study, and that is a study that many of you may well have been involved in, where all patients operated on during a 1-week period in October for each of the surgical disciplines, including urology, are developing mini teams to enter that data. And so far, 40,000 patients have been logged from 1,500 centres and 114 nations. So again, massive numbers of patients. It's going to be hugely impactful to tell us the risks of surgery moving forward. What about COVID surge cancer urology? Well, we are going to analyse the 2,700 kidney, bladder and prostate cancer patients managed during the pandemic and logged on COVID surge. And we're going to report those outcomes soon so that we can give real-time useful data to urologists. But we're also going to look at longer-term outcomes for patients managed during the first wave. What happened to those patients who had alternative treatment strategies? For example, neoadjuvant treatment of prostate cancer patients. What happened to patients who had treatments deferred? And actually that gives us the opportunity to study the natural history of these cancers, an experiment that we wouldn't normally ethically be able to undertake. So here's the plans that BERST have developed, funded by the Urology Foundation and with the assistance of the Birmingham Centre for Observational and Prospective Studies. So kidney, bladder and prostate cancers operated on between March and July, or managed during March to July. They may not have had surgery, it may have been deferred, will be followed up for bladder and renal cancer for 3 years with survival and recurrence related data being collected, and for prostate cancer only for a year, because our experts believe that even 3 years wouldn't give us useful efficacy survival related data. So we're looking at the outcomes of surgery in these patients. So if you collected data for COVID surge, we will be in touch. We've already been in touch once and we'll be in touch again. Please keep your patient keys so that we know the patients from your centre who were recruited to COVID surge who we need to follow up. So to finish, some reflections. COVID surge is the largest surgical study in history and has been a huge triumph for team science, with all contributors being acknowledged for their input. It's been massively impactful. You can see here the impact. Look at the altmetric score, almost to 2,000. It's the highest impact study. This is the first COVID surge study on cancelled surgeries, but the others are following suit. It's the highest impact study in the British Journal of Surgery, and one of the highest impact research outputs tracked on altmetric. These studies have been widely picked up in the media and have been useful to validate key elements of the perisurgical management of COVID-19. Longer-term follow-up studies provide absolutely unique opportunities to understand changes in treatment and deferment of management. And urology, thanks to BERST and TUF, is a leading surgical oncology specialty within COVID surge. So some acknowledgements. Many thanks to the thousands of investigators and participants in COVID surge, to Anil Bangu and James Glasby in the COVID surge organisation committee for their support of urology, moving forward some of the questions we're interested in, to the urology steering committee, and you see some familiar names there, to BICOPS and TUF, and of course to BERST, who have helped to deliver this from a urology standpoint. Thank you very much.
Good morning, Sean and Joe. Thank you very much for asking to speak about prioritisation of urological surgery in the COVID-19 pandemic. You must realise, of course, that in healthcare systems usually state or government run, that the effective use of resources, and within that, surgical prioritisation is nothing new. It's been estimated even pre-COVID that more than half of all the OECD countries routinely have surgical waiting lists greater than 3 months. And our population is getting older and their demands and expectations are increasing. So if prioritisation is going to happen, how has this been looked at before? There are essentially 3 strains of strategies to achieve prioritisation. You can see them here, based on waiting times and targets, scoring systems or guidelines and evidence base. The first, waiting times and targets, is a blunt instrument and not really useful between specialities. The second, scoring systems, is complex, often cumbersome and subject to surgeon provider manipulation. The third, although most logical one would think, is difficult to gather evidence that it's actually effective and does require an awful lot of data collection and management. Most of us heard or are familiar with the evidence-based interventions work devised by a high-powered panel of organisations listed here. The work aimed to standardise treatments and perhaps withdraw procedures thought to be of no or limited value. A committee decided upon 31 topics across all specialities, 4 of which were urological. The brackets, when I say 3 or 4, is because the 4th was PSA screening, and urology wasn't invited to this. It was initially only involved primary care, epidemiology and public health, but we've since changed that. The first call for comments on this work was in 2018-19, and the 3rd revision is due early next year. Some procedures have already been withdrawn or are now not offered, e.g. surgical procedures for snoring, except when it's obstructive sleep apnea. Varicose vein surgery and breast reduction is also no longer offered. In urology, they've had a closer look at cystoscopy in the diagnostic pathway of men with lower tract symptoms, in the management of stones, bladder outflow obstruction surgery, and PSA screening. The work in those areas has been largely sensible, well informed by urologists, and aligns with GIRFT. So that was pre-COVID, and then all of a sudden our worlds were turned upside down by the pandemic. As this is being recorded, the number of deaths worldwide has now exceeded 1 million, and there are over 43 million recorded or known cases of positive disease. This translates to almost 1 million cases in the UK with almost 50,000 deaths. When I was preparing for a BAUS SIU webinar talk in the middle of May, these figures were considerably lower, with just 7 million cases worldwide and about 500,000 deaths. So there's a huge challenge in an already stretched healthcare system, including the UK, so prioritisation once again has to be looked at. As you recall, the call went out in the middle of March to suspend all elective surgery to prepare for the possible tsunami of sick COVID patients, but all realised there was a range of patients awaiting elective surgery, from those with muscle-invaded bladder cancer, for example, to those awaiting a hydrocele repair. So we decided to provide some sort of guidance as to how patients might be prioritised in terms of need and who should get access to limited resources in roughly what order. 2 days after the government announcement, we adopted a scheme devised by our colleagues in London and rolled this out on the BAUS website and submitted this to all Royal Colleges and NHS England. Here is the first publication, and it was relatively uncontroversial based on disease biology and the likely risk of harm that any delay would likely cause. There then followed some intercollegiate messages on working with the pandemic, and also some concerns about the dangers of patients developing COVID in the post-operative period with worse outcomes, and also the danger of disease transmission via diathermy, smoke plumes, and laparoscopic robotic aerosols. This obviously had an effect on the ability to perform work and the prioritisation. Many urologists, including myself, suspected this was not quite as risky in urological procedures as in general surgery, where the guts obviously is opened every opportunity. So on the 30th of March, we published all the evidence there was, which wasn't very much, and this did help to get some urological units up to performing some non-emergency surgery more quickly. At about the same time, it was dawning that really we should have to have some sort of plan to reintroduce non-emergency surgery back into our hospitals in a sensible and justifiable manner. NHS England, via Prof Chris Moran and then the then President of the Royal College of Surgeons of England, Derek Alderson, asked the FSSA to produce such a plan document, the FSSA being the Federation of Surgical Specialty Associations. In BAUS, we also realised urologists would need some more detailed evidence than this, and therefore constructed a very comprehensive return to elective surgery pathway. And this was done by consultation with all our sections and fed this into the FSSA document, which then formed the basis for the NHSE document. There were some contentious areas, but the sections, trustees and many BAUS members really pulled together excellently. I'm particularly indebted to many people for this, especially David Thomas, Asif Munir, Session Agrawal, Ian Pearce, Ben Shalacombe, Darren Smith, Sheila Reid and Mad Shabir. They put a huge amount of work into this in often at short notice in coordinating their sections so we could feed this into the master document. This is the advice we published for the recovery phase, and it's given us a drop-down menu, so the specific advice for each section and diseases can be explored at greater depth. And these are still available on the website. As we're surgeons, we like to have concise documents, and all that guidance was put into a single 4-page document here. And this is basically covers the whole panoply of urology. And I must stress, it's a guide, not an absolute must, but it's a guide to help people to decide what they wish to do locally. To try to make this information more accessible and interactive, we took BAUS on its first steps into a webinar in May, which was hosted by the Royal College of Surgeons of Edinburgh. This covered the various subjects. The title was "How do we transition to the new normal?" The panel was made up of all the section chairs, and they really were fantastic. It lasted about 75 minutes. It was attended by over 500 delegates, and it was a very vibrant session. It's still available to watch on the Royal College of Surgeons Edinburgh website, should you so wish. The detailed information on urology prioritisation from the sections was summarised and fed into the master document collected by the then president of the FSSA, Mr. Nigel Mercer, a plastic surgeon based in Bristol. After much discussion and diplomacy, produced an all specialty document, which is a very large spreadsheet on the prioritisation of all surgical procedures, which was given to NHS England. Unfortunately, their systems hadn't got the power to read modern spreadsheets, so there's a bit of a delay there. As you can see, it's an extensive document and simply refers to procedures and not procedures when the procedures should be done and not by whom. For example, spinal surgery has quite a lot of competing specialties within it. The main document had several caveats, as you can see. And essentially the main ones are that it would be reviewed on a monthly basis, which I can assure you it is, and that any delay of surgery could be detrimental, and that must be borne in mind. It also recommended that a review needs to be done of somebody being on a waiting list for at the very least after 6 months following the initial prioritisation, and a few other considerations also. To help with the assessment of priority between different specialities, a recovery prioritisation matrix was devised, an RPM. This is shown here. But this is only intended for patients in the same category and only for those in categories P2 to 4, which we'll come on to in a minute. And I've not really heard of any wide-scale use of this matrix yet, but it may be a tool for the future. Turning to the urological bits of this master document, it can be seen that it really just echoes a summary of the more detailed advice we'd already published on the BAUS website. And we are asked as BAUS to check the master document monthly, make any submissions, corrections and adjustments. The grids are separate and contain these urological facets. Priority 1A is emergency procedures which need to be performed within 24 hours, for example, testicular torsion, Fournier's gangrene. Priority 1B is those procedures which can be done up to 72 hours after presentation, such as upper urinary tract obstruction or a penile fracture. Priority 2 is those procedures which need to be done within a month, for example, muscle invasive bladder cancer, so cystectomies there, or penile cancer. Priority 3s are those procedures which can be left longer than a month, but ideally performed before 3 months, for example, non-muscle invasive bladder cancer, intermediate or high-risk prostate cancer. Priority 4 are those things which can be left longer than 3 months. And this basically at the outset included most of female urology and incontinence surgery, andrology, Peyronie's, erectile dysfunction, and benign penoscrotal surgery. Recently, beginning of October, there have now been 2 categories added on to the P1 to P4, and this is P5 and P6. P5, these are basically categories for those patients on waiting lists who wish to defer their procedures. P5 only because of COVID reasons, P6 other reasons but still wish to remain on the waiting list for their operation. It should be realised that prioritisation is dependent upon so many other issues in the healthcare landscape. And GERFT is currently looking at pathways and imaginative best ways through this situation. I think we should ensure there's not too much duplication in these projects by various interested bodies, all of which you can see down below. When looking at prioritisation, I think there are several factors we should be aware of. The guides are just that, guides. And as well as a tremendous variation in regions and resources, there are many differences in the level of infection and epidemiology within the catchment population of the hospital. My own personal view is that whilst contacting patients to validate waiting lists is a good idea, the practical aspects are more tricky. If contacted by a clinician, the patient will not unreasonably want a mini consultation, express their discontent at the length of time they've already waited, and will want to know, not unreasonably, when their operation will be. The latter information is simply not available to give them reliably. For example, if a second spike arrives, we can't promise any dates for any patients. I think all this will take time, and if clinician-led, should be properly planned so it's effectively another clinic, which is properly job planned, and the patient's always available on the telephone and all the notes the patient's available in front of you, and maybe possibly recorded for future potential litigation. Undoubtedly, the pandemic has speeded up the adoption of more imaginative ways of working. As ever, we must gather the data to understand what is actually happening and what the effects of our actions have been. It's estimated, along with other surgical specialties, that urology surgical capacity and activities is around about 50 to 70% of the pre-COVID level. There's a huge backlog of work to get through, and with the instigation of new clinics and clinics coming back online, waiting lists are still being added to, whilst not really being cleared very much at the other end. There is a continuing difficulty with COVID light or units which are COVID free, and the reliance on the private sector might well be coming to an end at the end of this calendar year. The short, sharp pandemic we thought we were going to experience has now morphed into something very different. And unlike the first wave in spring and summer, this second sitting will be in poor weather, with both the population and perhaps the medical profession more weary and perhaps less confident with government leadership. I would not be surprised to see an increase in early retirements from the NHS and more issues with training and retention. So in summary, the situation is a difficult one to manage, and prioritisation is a small area in which we might be able to make some improvements or increase equality between conditions and specialties. We do know that there will be a parliamentary inquiry into the conduct of the pandemic, but maybe it's really time for the discussion to be had about what the NHS really is able, and perhaps more importantly, not able to provide. Thank you.
Hello, my name is John Kelly, and thank you very much for inviting me to talk at BICE 2020 in this virtual setting. I'm going to talk about delivering urological care at UCLH, which is essentially a hub model. I've chosen this picture of our hospital. It's a standalone urology unit in the heart of London. It's decked out almost as you would think for Pride, but in fact, these are balloons that were placed at the peak of the pandemic earlier this year. And it's a time that signifies huge energy to adapt, adopt new methods, work together, and deliver a service for patients, largely for us in terms of cancer and priority one, but one that was much needed when most other services were being drawn back. I'm not going to talk about how we instigated things such as screening and patient travel to hospital, etc. These are actions that we've all instigated throughout the pandemic. What I'm going to talk about is the processes and the methods that we use to set up what is now an ongoing structure with an ongoing pandemic. This is the first account of the significance of COVID-19 in the perioperative setting. It was an article that was published in eClinical Medicine, and it was a description of 34 patients in Wuhan who developed COVID in the post-operative setting. The post-operative mortality rate was 20%. And while this study has obvious limitations of size, we took it seriously. And of interest, all subsequent studies report similar findings and support that published here. So we now know that development of COVID-19 in the post-operative setting is associated with a 20% mortality, which is very significant. We were fortunate, in some sense, the UK was fortunate because it moved with a time lag behind Italy, France, and Spain. This enabled a level of awareness ahead of the pandemic, and I can distinctly remember Shan Allen, one of our co-chairs, talking in our governance meeting about colleagues contacting our centre to warn us of what lay ahead. So we were aware that there would be a rapid decline in elective healthcare services. This enabled UCLH in some way to prepare, I believe, well. We formulated a standard operating procedure and constructed what would become a clinical prioritization group. This was an engaged group between clinicians and managers, and we mapped out pretty much all aspects of how we would deliver care, including the independent sector. So processes were mapped out in the broad sense. The engagement was at the operational level with management, clinician leads, and obviously commissioning through NHS England. From the outset, we were inclusive with our independent sector, and we met weekly to design processes, to ratify pathways, and indeed to sign off on every patient that was receiving surgery. What was quite critical, I believe, was the autonomy that was given to specialities to develop their own pathways. This was at multiple different levels, and we came together around a shared decision-making and reporting. Examples for this would include the issue of, say, for example, COVID and the surgical plume. We were aware of reports from colleges that there was a risk of COVID viral particles being carried in surgical plume. We felt this risk was based on very little, if anything, anecdotal evidence and could be disregarded. However, we enabled some of our surgeons who felt that this was important to follow these guidelines, and others who felt that they could mitigate using, for example, filters to continue operating with minimal access surgery. Further, there were diktats such as don't use laminar flow surgery at one point. Our micro team said to us, switch off your laminar airflow at your peril. Other teams, for example, thoracics, wanted to use CT imaging preoperatively. These aspects were discussed on a weekly basis, and without being too prescriptive, we allowed some to continue, but encouraged others to cease. We also described a cold COVID surgical site. This was now what we know described as a green surgical site with a green and blue pathway. The UCLH urology is housed in a standalone unit separate from the main hospital. It has 6 theatres. We have a PACU, an intensive care, and a PERT team. Similarly, we availed of the independent sector centres with their own ITUs, robotic suites, etc. So in one sense, we were very fortunate to be able to establish a cold COVID surgical site early. Throughout the pandemic, we delivered 2,500 elective and priority 1 procedures, mostly cancer and endoluminal, between March and August 2020. We looked at the results of the first 500 cases, and Veru has actually reported this. And what you can see is that the time of audit was during the height of the pandemic here, with 30-day follow-up. Of the initial 500 cases with 30-day follow-up, we described the measures such as isolation, patient screening, limited face-to-face, reducing foot traffic and public transport, the use of PPE, and how we screen staff. This study showed that if we instigate measures to reduce the risk of developing COVID, only 2%, that is 10 of 500 cases, develop COVID in a perioperative setting. There were no deaths attributable to COVID, and the 30-day all-cause mortality was about 1%. 7% of patients developed Clavien-Dindino 3 or higher complications, and only 1 patient with COVID developed a CD3 complication. This showed us that surgery can be conducted safely during the COVID-19 pandemic, provided we take measures to mitigate risk. The report was picked upon by the media, and in particular the live broadcast news at the time. And here we see Viru, who was presenting to Sky News on several occasions about safe surgery. This was an initiative from NHS England to try and bring patients back to hospitals. So it was important that we have guidelines, and we're grateful to our own guideline body, BOIS, to other international guideline bodies, because without guidelines, we don't have a framework. But guidelines are guidelines. They're there to minimize the risk of developing COVID-19 while balancing the treatment options. But there has been and still is a paucity of evidence on which to base the assumptions and the guidelines process. And we noted discrepancies across national and international bodies. This posed a problem. How do we go forward with what we believe was a safe site for surgery when there are decisions that are not unanimous across bodies? For example, decisions to defer treatment for intermediate and high-risk prostate cancer, referring muscle-invasive bladder cancer to radical radiotherapy rather than cystectomy, not using laparoscopy because of aerosol formation, and not training, i.e. some of our guideline bodies said only experienced surgeons should perform surgery. We established what is now described as an accelerated Delphi process. This was largely due to Justin Collins and Zaf Tamduk at UCLH. And Delphi is a process of reaching consensus by opinion based on synthesis of evidence over several rounds. We enlisted an international consortium from across many continents. There were 35 members. And in particular, we had representation from the infectious disease experts, notably virologists who had worked on the Ebola crisis some years before. So we designed a method for attaining rapid consensus through 3 rounds, which could be completed within 72 hours. This is an example of how we felt it was necessary to develop prostate pathways during COVID-19. They were very different to how they're described by very many of our national guideline bodies, but essentially they are adaptive. They allow for patients to move from one aspect of care to another through follow-up and through decision-making. And what's important about this is that going forward in a pandemic, which at the moment we do not see an end to, we have a way to adopt or change our practice for patients and for how we deliver service. This article will be published in the BJUI and is currently in press. We also used aspects of best practice to change some of our established pathways. For example, in radical cystectomy, we have a high volume clinic, and not only moving to face-to-face, but we shortened the time during COVID between the decision to operate and the time to surgery. Many factors were attributable to creating this shortened time, but we showed that during COVID, right through the height of the pandemic, we could operate on patients up to an age of 80 years of age, patients who are less fit and with good outcomes. In doing so, I believe that we've shown that we can deliver cancer services throughout the pandemic, and indeed we can continue to do so with perhaps lower priority cases in the future. We also looked at training. It is true that training will be impacted. There's no two ways about that. but we're entering a new way of training where we have got telepresence. We're hearing other talks on telepresence at BICE this year, and we established a Delphi to set out what could be the standards for a new training environment where telepresence is part of our routine, part of how our trainees learn, and indeed how they attain skills. We used expert opinion, and this again was an international body which has been published in European Urology Open Science, but it promotes the standardization of training in a reproducible way, improving access to experts and enabling machine learning as a way of feedback to trainees and as a way of establishing objective metrics of outcome. We didn't just look at our own centres' work, we also audited centres across the UK. We looked at 13 of the large centres providing cancer services. This was a multi-centre analysis of 30-day outcomes. And we looked at key operations: radical prostatectomy, radical cystectomy, and nephrectomy and partial nephrectomy. Again, this was during the peak of the pandemic, 1st of March to 5th of May. In total, 598 operations were performed. 4 of that number of patients, 0.7%, developed COVID. There was no COVID-related mortality. 83% of the operations were performed minimally invasive, and almost 40% were described as training procedures. We also showed that the risk of a patient developing COVID was not related to longer hospital stay, training, or higher ASI grade. This was important because it highlighted to us that many centres were doing as we did. They were adapting to change, they were carrying out complex surgery, they were training, and they were doing so in a safe environment. So in summary, what has the COVID-19 pandemic taught us? Well, I liken COVID in some sense to a pulmonary embolism. If a patient develops a pulmonary embolism in the post-operative period, it's associated with a 20% mortality. Of course, it's easy to mitigate against the risk of developing a pulmonary embolism. It's a lot more complex for COVID, but we can show that if we do so, we can provide surgical services across complex operations. And in the future, we must therefore look to lower priority surgery. We also show that if we don't measure how we respond to risks, there is a potential that we adopt some aspects of risk that are unfounded. And as we develop evidence, this will change, but it's important that we remain measured. What we're doing with COVID as a nation at the moment is not what we did in the first wave. And we too, as surgeons and clinicians, must be adaptive. We must change how we deliver services, how we classify patients and stratify them. And importantly, we see no reason not to train surgeons. This should continue unabated, but must in some sense alter to the new environment, and telepresence obviously is going to be a large aspect of that. COVID, above all, probably taught us that change doesn't have to be challenging. Coming together as an NHS group with all aspects of healthcare workers working to improve the outcomes, we show that although challenging, we can deliver services. Thank you very much for listening.
Good afternoon, everyone. On behalf of all of us, I would like to say a huge thank you to Grant Stewart, Duncan Somerton and John Kelly for the time and expertise that they've put into preparing such excellent talks. Listening to them speak, I think we'd all agree that the overwhelming theme throughout their talks was that of collaborative working. Certainly, if it hadn't been for such an amazing team ethic in healthcare, the last 8 months would not have been possible. Thank you, Grant, for updating us with the COVID surge studies. We'll all be watching eagerly to see the next results and what we need to change in our surgical practice going forward. Incredible to think that the largest study in history has not only been carried out during such demanding times, but has been led by trainees who've managed to join forces across the globe. Really impressive work. And of course, well done to our own BURST team and medical students for coordinating all the urological data. Duncan and John reminded us of how worrying it was for those of us who continued to operate throughout the peak of the pandemic. I remember at the very beginning, standing dressed in my lead and FFP3 mask and very cumbersomely heavy welder's helmet outside theatre as instructed while my patient went off to sleep inside. And I remember looking up at the air vents that were flapping and really questioning whether or not that was the best place for me to be standing as I'd been told to do. At that time, there were so many unanswered questions and advice seemed to be changing on an almost daily basis. So now we know more. And these talks have shown us that during the peak, urological surgery was safe, so long as we took the relevant precautions. And outcomes are better for patients if they followed a green or COVID-free pathway. We also know that we should be waiting a minimum of 4 weeks between a positive patient test and their operation. The section leads have given us detailed advice on the BAUS website to help with the recovery phase, and they advise us that decision-making should be shared between specialties so that we don't duplicate time and effort. And as John said, the training should continue for our juniors, but may need to be adapted. As a final thought, we need to take time to remember that during the first peak, staff rallied together with enormous energy under exceptional circumstances and a really risky environment. And we need to recognise, as Duncan said, that many people are now physically and emotionally worn out. One of our intensive care consultants at UCH said to me 2 weeks ago, "Sian, I just don't know if I've got it in me to do it all again." So we really do need to take time to look after each other at the moment and appreciate we've all had different experiences over the past months and might need different support. So very many thanks once again to all our speakers, and thanks to Joe Phlip for chairing this session with me. Thank you. Have a good afternoon.